Good morning and a warm welcome to everyone who's joined us. Thank you everyone for making it on time. We really appreciate. I see there's already over 100 people who have joined us, so that's really fantastic. We have a number of registrations for the webinar, so we're just going to give everyone 5 more minutes to join us. While I wait, I would just like to check that we have our speakers in the room with us. Professor Aluwalia, if you can kindly just turn on your camera so we can check that in the sound.
Hello, Stephanie. Can you hear me?
Yes, I can hear you. Yes, we can see you as well. Fantastic. Thank you for joining us. Professor Paswana Mafuya?
Yes, good morning.
Morning. We can see you and hear you. Thank you so much for joining us.
Sure.
Good morning, Prof.
Good morning. Good morning, Prof. Nick.
Ms. McGoy, are you with us?
Tavi Singh? Greetings, Tavi Singh. Can you hear us?
Yes, I can hear you, Prof. Good morning, everyone. Am I audible?
Yes, you're audible and we can see you. Thank you so much for joining us.
Thank you.
Fantastic. So we have most of our panelists who are here. We're just waiting for our colleague from Department of Health. But thank you everyone again to everyone that's joined us for our webinar this morning. We are just going to give 4 more minutes to everyone for people to join us and to get online, and then we will begin with our webinar for today. Thank you very much. Good morning, everybody, and a warm welcome to our webinar this morning, where we're going to be looking at the implications of the immediate cut of USAID funding on South Africa's HIV and TB response that is being hosted by ourselves, Higher Health, in collaboration with the Department of Health, the higher education sector, and SANAC. Thank you very much to those who have joined us. I'm sure there will be people who are joining us as we go along, but we will commence with the webinar. As an introduction, my name is Stephanie Hendry. I'm the University Program Manager at Higher Health, and I'll be chairing the webinar today. We have a panel of speakers who have joined us, and will each be providing insights into the topic that we'll be discussing, and then we will have a question and answer session at the end. In terms of house rules, please note that everyone is muted and has their camera off, but we will have a question and answer session at the end of the webinar. In the meantime, if you can kindly just put your questions into the chat box as we are moving along, and then we will have answers to those questions towards the end. The webinar is being live streamed, it is being recorded, and everyone who has registered for the webinar will have access to that recording, and we'd really encourage you to please ask your colleagues to join us as we discuss this very important topic today. So I am just going to ask our esteemed panel to kindly put on their cameras. I'm just going to do a round of introductions of our speakers today, and then I will hand over to the Higher Health CEO to do the opening and welcome. So today we have our CEO, as I said, of Higher Health, Professor Ramneek Aluwalia, who has joined us and who's going to be giving the purpose of the webinar, the context and the outline of why we've brought the sector together today. Professor Aluwalia, if you'd just like to greet the House today.
Hello, everyone. Greetings and thank you.
Thank you, Professor Aluwalia. Our next speaker will be Professor Refiloe Paswana Mafuya. She is the Deputy Vice Chancellor of Research and Innovation at the University of Johannesburg. Professor Refiloe, welcome this morning. If you'd just like to greet everyone.
Thank you and good morning, everyone.
Thank you. Thank you so much for being here. And then we have Ms. Tabi Singh Mogoy, who is an Adolescents and Young People Technical Lead at SANAC. Thank you for joining us this morning.
Good morning, Stephanie. Good morning, everyone. Pleasure to be here. Thank you.
Fantastic. Thank you so much. Thank you for joining us. And again, a warm welcome to everybody. I think this is a critical issue that's really kind of created quite an impact, not only in the sector of higher education, but as a country as a whole. And as Higher Health and our partners, we really thought this is an opportune time for us to have a discussion on the impact of the cuts in USAID funding, particularly in the HIV and TB response space this morning. So I am going to hand over to Professor Alawalia.
I was thinking, Stephanie, I was thinking
yes.
that because Professor Refilwe has to leave, and she did speak to me, Professor Nancy, I would really urge that we take her presentation first, as she has to go. She's on a visit at Soweto campus. So we take her presentation, but colleagues, from my side, I'll come immediately after Professor Nancy to do my opening address and put the context much more deeper. But Prof, thank you for coming. In fact, why am I interested that Prof Mafuya presents the first presentation is because she will set the scene also, because she did this research quite a while back in a publication around how self-reliance Africa should be, or every country should be, from foreign aid. And that brings the context of where we find ourselves as a country and post-school education system. But I would rather, with your permission, Chair, if I can ask that we just swap myself around with Professor Mafuya. Thank you.
Absolutely. Thank you so much for giving us the time as well, Prof. Over to you.
Thank you very much. Let me share my presentation. Please let me know if you are seeing it.
We can see, Prof.
Visible. Thank you.
Oh, okay, let me just. Is it on slide mode?
Yes, it is.
Oh, okay.
Thank you.
All right. Thank you very much to your program director and to the CEO of Higher Health and the organizing committee for inviting me to share the work, the scoping review that we did on country ownership and sustainable programming of the HIV response in South Africa in 2022. And indeed, as Prof. Nick said, I believe this presentation will set the scene for the engagements we're going to have later. And as mentioned, I'm the Deputy Vice Chancellor for Research and Innovation at the mighty University of Johannesburg. And I am privileged to serve on the Higher Health Board for 8 solid years of lots of excitement, evolution of Higher Health to become a force to be reckoned with in the country, and so many lessons, that one had to go through as we engaged on how to position Higher Health as a key institution in South Africa. And this webinar is actually proof of that. My presentation has 6 parts. Part 1 is about disclaimers, which I thought I should mention because this is not a fresh presentation. Disclaimer number 1 is that a presentation on this was made at World AIDS Conference 2022 in Canada under the satellite session called Quest to Reach HIV Epidemic Control. And the title of my presentation was Country Ownership and Sustainable Programming in South Africa. And disclaimer number 2 is that this presentation, as Prof. Nick already pointed out, is derived from a published paper at the Southern African Journal of HIV Medicine, published in 2023. And disclaimer number 3 is that the work from this paper and presentation is based on an SAMRC-funded project called Harnessing Big Heterogeneous Data to Evaluate the Potential Impact of HIV Responses Among Key Populations in Generalized Epidemic Settings in Sub-Saharan Africa. Much as this work has been presented before, it is as relevant as it was in 2022, and it will continue to be relevant for South Africa until we achieve full country ownership and sustainable programming in terms of our HIV response. So part 2 is about background. Justifiable concerns arose, and this has been a subject that has been lingering for a while regarding the extent to which our country's HIV response can be country-owned fully and sustainable, given substantial foreign investment and technical support. And to this end, we assessed the extent to which South Africa's national response can be country-owned, with the aim of providing insights into gaps in country-owned HIV programming and coming also up with practical recommendations for closing them. I like the capturing of an interview by Dr. Errol Paplos Mendez in June 13, 2013, where he says we must crowd in local resources. Host country-led investment is absolutely critical. Countries themselves must take ownership and accountability in the fight, and local civil society has a critical role to play in ensuring sustained commitment and investment at a country level. This was in 2013. Hence, I said this subject has been lingering for a while. I'll outline briefly the methods we followed for the scoping review. We used a range of sources, both published and unpublished, extracts and figures, and triangulated this information for a comprehensive, up-to-date review using key terms to allow us to sift as much relevant information as possible. And this included looking at national policies and programming information, and I must acknowledge SANAC for the pivotal role they played in assisting us on having information like reports which were not necessarily in the public domain. So we used their technical and annual reports, as well as conducted some consultations with SANAC technical leads, because it would have been impossible to compile a review of this nature without those that are leading at the forefront. And then we adopted the USAID approach in analyzing our country ownership. This is called the Global Health Initiative Framework, which has 4 domains. And I'll speak to the domains as I present the results. And I need to mention that these domains are not mutually exclusive. So some of you, as I present, might feel, oh, these results could have formed part of domain 1 or domain 4. So they are not mutually exclusive, but we've tried our level best to ensure that we provide a coherent message in terms of where the country is at. So part 4 is the results by the dimensions of the Global Health Initiative. There may be other frameworks, but in this case, we used this one. So dimension 1 focused on political ownership and stewardship. Does South Africa politically own the response? Is there some form of stewardship? And there is no question about that. There is strong political will with regard to epidemic control. We know South Africa has the largest HIV treatment program in the world, and I'll talk to some of the ownership points in the next slides, because they are, as I mentioned, the dimensions are not mutually exclusive. The country has been at the forefront of signing progressive UN declarations of commitments in the quest for epidemic control. It is clear that there are aspirations for what should be accomplished and strategies that are aligned with national as well as international priorities. And the country has developed a robust and is currently implementing the South African National Strategic Plan for HIV, STIs, and TB 2023-2028. and we know there have been other NSPs before this, which speaks of the commitment that the country has. So the country has adopted the WHO guidelines, test and treat, and so on, which have been very instrumental in strengthening our response. And the country has developed policies around key populations whom we know are drivers of the epidemic in terms of HIV transmission and acquisition, a number of frameworks that the country has put in place to show ownership and stewardship of the HIV response. And the South African government has also ensured full costing estimates to demonstrate financial transparency, guide sectoral and provincial government in budgeting. So it's not only a lip service, the government has dedicated funding to ensure the implementation of the NSP. So dimension number 2 focuses on institutional and community ownership, where the main question is whether communities are used as a vehicle for delivering HIV programs. And in terms of this domain, what we found out was that the country is committed to having HIV programs being community-led, driven by the slogan, nothing for us without us and leave no one behind. The government works with communities, civil society, private sector partners to actively implement the NSP. And there are technical experts that are involved, and the concern here is that there is reliance on donor support and investments for building technical capacities of community-based organizations. And you can imagine what is happening now, and I'll leave that to my co-panelists when funding is withdrawn with regard to CBOs. They will definitely be highly impacted. So the South African government largely, and this is a concern, relies on donor funds for key population programming, which is mainly led by community-based organizations. And again, key populations are very key in the HIV response for us to realize epidemic control. There's a presentation that I shared elsewhere, and the paper is in the public domain, demonstrating the consequences of leaving key populations behind and how much impact can we can potentially lose if we leave them behind, and demonstrating the increase in impact by focusing on populations that are drivers of the epidemic. Dimension 3, capabilities. Yes.
Just a time check. 5 more minutes, please. Thank you so much. Apologies to interrupt.
That will be great. Dimension 3, capabilities, which refers to whether the country has effective workforce, organizations, and systems to achieve priority outcomes. And on this one, South Africa has robust information management systems. It has data collection platforms. It has, but there's a need to strengthen accountability. Hence, we talk about the development of the situation room, where decision making can be based on this data that we have on a real-time basis. And South Africa also has a human resources plan, is doing much better than other African countries, but there are still staff shortages, and there are procurement issues and supply issues. So much as we have positives in terms of capabilities, there are also gaps that require additional funding. And in this regard, we have relied on external funding or international funding. Dimension number 4, which actually speaks to the crux of today's engagement, mutual accountability, including finance. The South African government is the largest spender, as we know, spending about 70% funding on the HIV response. And the concern here is that 24% of of the response is from international donors, PEPFAR, and 1% from Global Fund and others. and I don't want to read, you can read the captions there for yourself due to time, but the issue here is that although there is huge commitment in the country, there is reliance on international funding, especially when it comes to HIV prevention, because most of the funding in the government focuses on HIV treatment, and HIV prevention is mainly funded by international donors, and we know what will happen if HIV prevention is overlooked. We still have a higher number of new HIV cases than we would like to see, and because of that, we would still need to have higher number of people put on treatment, which makes the program ungovernable. So it is of a serious concern. Concluding remarks, there is evidence that as a country, we are trying our best to champion a sustainable HIV program. We are progressing well along the spectrum of country ownership. We have policies, commitments, initiatives, and investments. We have surveillance system. They are not without weaknesses. There's continued commitment of the country to be the primary funder. However, we just don't have enough. There are gaps. Sustainability remains a challenge because who's going to help in terms of HIV prevention? It is not that the country does not want to. We are a developing country. We have to own the response, but we also have to partner with other countries. And by so saying, I am not shifting the ball. It is just the reality. So we need to ensure that we continue to leverage community-based strategies to reach high-risk populations that are mostly, needed for us to reach epidemic control. And we need to have buy-in from the private sector, which contributes 1% or less. The local businesses, we need to put our hands together. This situation challenges us to do so more than ever before, so that even if we have to get external funding, it has to be extremely limited. A multi-sectoral response is important. This has been a buzzword for longest. And in conclusion, this work involves a number of institutions and a number of people, including SANAC, and the references are as listed. Thank you very much to Higher Health for organizing this amazing, pivotal webinar at a critical time in our history. Thank you so much.
Thank you so much, Prof. That was really an insightful. I see you can see all the hearts and clapping hands and thumbs up that are coming through from the attendees. A really interesting and a really, as you say, pivotal time for this presentation, and fantastic work that you and a team have done. Thank you for also keeping to time. It's much appreciated. I think for the colleagues that are online, if it's in order for you, with you, Prof, we will share the slides with the attendees who have registered for this program.
Yeah.
So
may I interject just for a minute? Yes. Because I'm leaving, I've organized the second author, Dr. Edith Palani, to remain on the session so that should there be questions that pertains to my presentation, she can then answer them.
Fantastic. Thank you so much, and really appreciate your time. We're really honored to have had you. Thank you, Edith. Travel well, and we'll feed back to you, Prof, on any of the questions that come through. Thank you so much for joining us.
Thank you. Thank you.
Thank you. Again, thank you if there's colleagues that have just joined us. We have received our first presenter today. Before I hand over to the CEO of Higher Health, I just want to acknowledge Mr. Rampelani Moere, who's joined us from the National Department of Health. Good morning, sir. How are you? I just want to see that we can see you and hear you.
Good morning, colleagues. Good morning to everyone. Good morning, Professor Ramnik, and my apologies for joining late. There was some technical glitches, but I'm happy I'm here. Good morning. Thanks very much.
Fantastic. Thank you. It's perfect timing. So thank you very much for joining us this morning. Okay, I am going to hand over to the CEO of Higher Health, Professor Ramnik Ahluwalia, who is going to give us the purpose of the webinar, the background and the context for why we're here this morning, and the panel that's been put together in terms of discussing the impact of the USAID funding pause for South Africa's HIV/TB response. Please do put your questions in the chat if you have any, and we will go through that when we do the Q&A session at the end of the webinar. Thank you so much. Over to you, Professor Lualia.
Thanks, Stephanie. Greetings to everyone, to all the speakers, and very grateful, Professor Mafuya, for putting the presentation. I think you have set the scene for why we are discussing this meeting together. I'm equally grateful, DDG of Department of Health, my very good friend, Dr. Rampilane. It's very critical that Department of Health is there in the meeting and led by our DDG, who is actually facing the storm the biggest at this moment. And his time is very critical and essential. So I'm very grateful, sir, you've joined. I'm equally grateful for Sanak and Tabi saying thank you for having the heart to join, despite your busy schedule and diary. And we are the pillars of the system: Department of Health, South African National AIDS Council, the academia, the system that is helping our HIV response and TB response in this country. It is a sad day. There's no doubt that having to lose a great partner in the form of PEFA, USAID, that helped this country tremendously, specifically in our HIV prevention response, to let them go, it's a challenge. In fact, I am going to say that the challenge is more for the African continent, where 60 billion rands, $60 billion are in question, and also for South Africa. Our 17% of investments on only HIV and TB came from PEFA. So what happens from here on is the big question. I wanted to inform you that I will give higher health example, and this is very much about the post-school education and training system, that when South Africa, way back in the 2000s and early in the late 90s, when HIV pandemic grappled our system, and the government took it upon themselves that this is a huge pandemic that affects our daily livelihood. Critical programs, and I'm being grateful that I've been a big advocate of this since I joined Higher Health since 2011, is the fact that critical populations like the institutions of higher learning, post-school education, where young people are, hope of a mother is there, where the next economy of South Africa is dependent on, where we are having plumbers, miners, electricians from our TVET colleges, our doctors, scientists, academia, engineers, workforce, whether anybody you see in employment, when you go to Mug and Bean, when you go to any place else, there are skills that people are using on day-to-day basis to earn a living. And that's how our country moves forward. Should never be dependent on foreign aid. And I'm very grateful that the country listened to that. And critical key populations, our clinics in Department of Health, our ARVs, our pre-exposure prophylaxis, our medications, our condoms, our biomedical services must not be dependent on foreign aid. And a very grateful Department of Health had that resilience from the very beginning and build those structures. I'm sure DDG will give us deeper insights onto it. Similarly, education sector, basic, but most importantly, us as higher education, we were absolutely resilient. We built this knowing this could happen any day. These fears of PEFA leaving was not new to South Africa. We saw every year these discussions happening between PEFA of reducing the amount or withdrawing the funds. So what we did was we built higher education in critical populations out of PEFA and out of foreign aid. As far as possible, a very strong, resilient model that should this day happen, which happened, the country will not grapple, system will not grapple, our people will not grapple. So I'm very happy to not happy, but at least to inform that those resilient systems are going to now come in place. In post-school education training, the 10,000 peer educators that all of you help us, universities, our TVET colleges, and day-to-day help in prevention. They are our unsung heroes of South Africa. They are not dependent on any foreign aid. They come through our system. First-year students take it upon themselves to look after themselves and their other peers in the system. They look after 2.5 million South Africans in the post-school education. Those 10,000 will remain despite PEFA goes or does not stay. The second important thing is the issue of our field workers. We came with the government much earlier to say, let's create jobs. We work with the vice chancellors, let's create jobs in our clinics. I'm always saying our unsung heroes are our nurses, our healthcare workers, our social workers, our psychologists, our counselors, which are in our universities and our TVET colleges with higher health, every day and night putting. Just to let you know, they are self-reliant and self-dependent from our domestic investments. What we do is we create entry-level jobs, we bring them to higher health, get mentored through our 9 provincial MOUs with the Department of Health. And Rampilane, I'll always be grateful. This legacy is where the resilience comes in. The 9 provincial MOUs, the 52 district MOUs with the Department of Health, where you provide supplies, commodities to our clinics in institutions of higher learning. You provide mentorship to our nurses, our clinicians, our care workers, our teams. And through them, they provide empowerment to our 10,000 soldiers, which are our peer educators, which I'm very proud of. The entire system is not dependent on foreign aid. What we are going to be impacted was our down referral. And DDG, this is where our big partnership will come more stronger now, is our down referrals for services on ARVs, sometimes on pre-exposure prophylaxis, on our TB treatment. In those 27 districts where implementing partners of PEFA were there, we could do easily, not putting burden on our Department of Health sites. But in the other 25 districts, Higher Health referred directly with the Department of Health, worked in partnership with the DOH with the down referrals. What we're going to do now is we're going to change the 25 provincial model, 25 district model to all 52 district model. And that is why our DDG Rampilane is here in the meeting. Sanak is there in Thabising to pledge that we're going to do it. We have the strength. We have our system not affected by PEFA. Our prevention program will not go down. Our 10,000 peer educators, our soldiers will be still intact. And more importantly, our down referrals will still be there. We were 3 people walking together in the campuses on our first things first when we brought services on the sites as wellness days. What we do is when employee and wellness days happens for all employees by private sector, by medical aids, Higher Health through first things first in partnership with DOH and SANAC always made sure that free services, whether it's dental, eye, HIV, TB, blood pressure, sugar, come as part of first things first on campuses routinely, so that our young people, the underprivileged South Africans, get services routinely on our sites. Yes, we will lose a very big partner who is to bring services on HIV and TB on sites, but the other partners will still come. Department of Health will be with us like it always came. Higher Health will be there with its services. Our own institutions will be there, and we will work hard. Our global fund is our big strength, and I know Sanak will speak about it, and Thabising is leading it from the front. We're very proud of this partnership. We're going to work very hard with Global Fund to see, can we not bring PrEP on our sites? Can we not bring ARV on our sites? Can we continue our initiation so that those 27 districts where we were not initiating ARVs, can we initiate ARVs on our campuses? Can we initiate our PrEP on sites? Can we bring 6 months injectable PrEP into our institutions? Our campuses are vulnerable. DDG and Sanak, Just to let you know, our campuses are vulnerable. 96.4% of our population in TVET colleges come from very poor backgrounds, extremely poor. 99.7% of our population in community colleges come from very poor backgrounds, highly vulnerable. This is our economy. This is our future of South Africa. This is where the population keeps turning. 78% of our university population comes from very poor backgrounds. 78%. That's our 2 million plus South Africans every year coming, going, coming, going. But the same 2 million South Africans are living in households with their brothers, their sisters, unemployed youth, with their family members in the same community, around the same site, in every village of South Africa where higher health is, every township of South Africa. You talk Alex, you talk Soweto, you talk Guguletu, you talk Tembisa, you talk Ulundi, Bizana, anywhere in this country. Higher health is present through our community colleges, our TVET colleges, our university campuses. So we can use our 10,000 foot soldiers, our peer educators, we can build them more and take them to community. If we find a TB positive, we have to go to their family because that's where it's coming from. We have to go to a residence in case it's a university, but mostly day scholars are in TVETs and community colleges. Most of these problems are through a taxi rankers who exploit our young girls in TVET colleges. Our data is very clear where the HIV epidemic is coming from. How do we help ensure that transactional sex don't happen? That's prevention for us. That's what we are fighting, this. Unplanned pregnancies, bringing contraceptives on sites, building an economy of this country. To conclude, we are resilient. Higher health was and post-school education is very resilient. It's self-reliant. It's very domestically supported. It's a critical population of this country. What we will look forward is a very strong partnership with Department of Health, an extremely partnership with SANAC, with the World Global Fund, but very critical partnership with, as we have with NPA, Department of Justice, because of gender-based violence in Tutuzela care centers, like we have built that strong partnership with SAPS also, so that more and more other services come. Higher health prevention program believes in what President Mandela said, education. Educated South Africans. Educated South Africans are less vulnerable to HIV. Educated South Africans are less vulnerable to GBV. Educated South Africans are always, education is prevention. So higher health introduced a curriculum as part of the core curriculum across all universities, accredited by QCTO. 8 modules, fully credits. In the first qualification by the Cabinet of South Africa that allows an NQF level 1 to join in and exit out with higher health, or NQF level 5, which is advanced certificate, building CVs for young people. Civic education, ethics, human rights, constitution. Human rights and ethics is critical for us. Number 2, gender studies, gender-based violence, gender equality, gender transformation, transforming mentalities. Mental health, 3rd module, 5 credits. Stress, anxiety, suicide, every young South African needs to know. Number 4th module is disability. What are the forms of disabilities? Everybody is vulnerable to disability. 6% South Africans live with disability. One of us can be. What is a reasonable accommodation package? What our employers can do? What an employee can do? What a student can do? Number 5th, comprehensive sexuality education. We don't believe just in CSE. We believe CSE interlinked with everything. Because we can't solve HIV if we don't solve the problem together. Number 6 module, drugs, alcohol addiction, abuse, prevention. 5 credits goes with drugs and alcohol program and physical well-being. Physical well-being, which is nutrition and health. Module 7 is climate change, climate with health, climate with gender, hydrogen economy, blue economy, green economy, 14 credits. And the last but not the least, the biggest module, financial literacy, poverty. This is the only qualification linked to 17 SDGs. We are making sure TVET by TVET, every weekend from Friday to Sunday, on our computer labs, on our mobile labs, young people are joining and doing this. This is prevention. And we can win this self-reliant in this country. So colleagues, just to conclude, we can win this. And South Africa is very resilient, very strong. We have systems where we can, but we can't win this alone. We need to work together. This is the time for unity. This is the time for consolidation, and this is the time for our efforts. We will do full force prevention, first service on ARVs, PrEP on our sides. And then if there is a further down referral complication, we will have our Department of Health standing with us, and we will ensure every young South African is looked after in this country. With that note, thank you.
Thank you very much, Professor Alawale. I think some really critical insights and giving the context of where we are and the things that we need to do in order to mitigate the storm that has hit South Africa in terms of our HIV and TB response planning. So with that, to everyone, we are going to have our next speaker, which is Mr. Rampalani Morewane. As we've introduced, he is the DDG at Department of Health. Please note, I see some hands. Please note that you can put your question into the chat, and we will answer those questions when we have our Q&A session towards the end of the webinar. So please do feel free to put your questions into the chat box, and we will answer those. Thank you, Mr. Morewane. Over to you.
Good morning, and good morning to the CEO of Higher Health, and thanks very much for such powerful and very, very inspiring, intro and into the purpose of this webinar. I had prepared some slides, but if they are not available, I can still talk to them. And the pity is that we may not be able to see them. But just to say, to echo the sentiments expressed by the CEO, Professor Ramnik, that reliance on foreign aid has always had its own problems. And some of us that have come up through the ranks to work within donor organizations and with donor organizations, there's always been what we call the life after donor funding. So when this situation happened, it wasn't anything new, except that it was just sudden, such that we didn't have enough time to respond. Now, what do we do? I'm going to very, very quickly, really, very, very quickly take you through some of the slides. And I don't intend to read all of them, but I really want to just take you through the key highlights of the work we've done and the work that has been done and what we continue doing. The first thing is that the South African government got notified about the withdrawal through various sources, unlike what is normally the case, where you would get a communication coming through. We didn't get that. So we got it through those that are affected on the ground. Again, it just shows you of how communication can go wrong, or sometimes it may not even happen the way you think. So I'm going to go very, very fast on these slides. I'm going to just deal with a brief introduction and background. And you remember that I'm sure just now, Prof spoke about 27 priority districts. I'm going to deal with that. I'm going to show the resources that are available for HIV and AIDS and TB response and the implications of the executive orders, mitigation measures, and I'll conclude. The purpose really is to look at the impact of the USAID's funding decision and the strategies to ensure continuity of HIV and TB care within the post-school education and training sector. We want to do this in line with the purpose of the webinar to ensure that no student is left behind in accessing life-saving medication and treatment. And in that area, we want to focus more on ARVs, TB treatment, pre-exposure prophylaxis, and post-exposure prophylaxis. Just as an introduction, I've already covered this. So because we didn't receive any formal communication, but we didn't want to wait until we received formal communication, we started acting. Just the list here, it just shows you the number of people who have engaged in trying to firstly make sense, but also pleading for support, but thirdly and most importantly, assuring those that are affected by this withdrawal that we're doing something. Having met all important people, you'd realize that towards the end, we then say, we engage PLHIV sector, one of the 18 civil society sectors of SANAC, and in fact, we intend meeting them now face to face on a date that will be communicated soon, but much sooner we'll meet with them. We've already met the implementing partners because we're meeting sector by sector, subsector by subsector, so that we don't muddle issues. We're also engaging on finalizing the implementation of the sustainability framework that's developed by SANAC. And regarding our relationship with Higher Health, we have come a long way, as my colleague has said. I mean, on the campaign of First Things First, we are together. Capacitation of higher education and health providers on various methods of work, contraceptive, adolescent, youth-friendly services. We're also training those that are rendering services in the campus clinics. On NIMART, we work closely with provincial managers to support the outreach, particularly for the clinics that are in the catchment space. Youth festivals and TVET colleges. I've personally been there with Prof. We know what it means to have been on the ground, and that all higher health events are held, are planned jointly and held together, and therefore we work hand to hand, hand in hand with the higher health institution. Now, the 27 priority districts that Prof spoke about are here. The listeners, participants on the platform should be able to recognize their districts. In Eastern Cape, we've got 6 districts, 1, 2, 3, 4, 5 districts. In Free State, we've got 2 districts. In Gauteng, we've got 4 districts. In eThekwini, we've got 7 districts. I mean, in KZN, we've got 7 districts. In Limpopo, 2. In Mpumalanga, 3. Northwest, 3. And Western Cape, 1. So certainly Northern Cape has no district that's supported by PEPFAR. For one reason, they really didn't have a high burdened district. This slide just shows the deployment of the resources, human resources, that's there on the ground. In total, we've got 271,606 staff members that are in the patients facing service delivery points for HIV and AIDS. But if you look at the middle row, middle column, you'd see there we've got 256,000 of them that are funded by the Department of Health, which means we're funding the biggest chunk, and 15,000 are funded by PEPFAR supported partners. So you can see that it's about 4.5 or so, 4.6%. Now this slide just shows, again, to date, how much money we are spending. South African government today, as a government from public funds, we're spending 74% of the efforts to address HIV and AIDS and TB, and private sector is giving us 2%, which mainly comes from medical schemes. And both public and private sector together, they're giving 76%. So the donor funding is about 24%. What does it mean? It's 17% of PEPFAR and 7% of Global Fund. So the rest you can read as to how much does it really mean. So we need to deal with the implications of the executive orders. What did they do? Once this was announced, we knew that all projects that are funded through PEPFAR in line with country operational plan are in trouble, because we signed our COP23 just last year, which was running for 2 years, 2024, 2023, 2024, 2024, 2025. So it will be ending in September, and I will deal with it in a second. And then we knew that patient care and other health outcomes will be affected. achievement of the second 95 of our 95 targets going to be affected. But we know that we have done some work in that. And we're also on the verge of implementing transition from 3 multi-month dispensing to 6 multi-month dispensing, as announced by the Deputy President. We know that one also may take a knock. In terms of provision of pre-exposure prophylaxis, we also knew that it was going to be affected. In terms of scaling up of targeted universal testing for TB, and also linkages for drug-susceptible TB patients, and those that are drug resistant, that was going to be affected. So what did we do? The department then issued a circular to all provinces to ensure that there's continuity of care. So this involved the redesigning, rearranging the work, redeploying the staff, doing task shifting, and prioritizing the 3 multi-month dispensing, encouraging HIV self-testing on the ground. And also that we should implement the 28-day delay collection allowance for patients, because sometimes patients delay to take their treatment. Now, on the long term, we are actually doing a prioritization exercise. We've received the spreadsheets that deal with the number of people that are on the ground. We're analyzing them. In fact, we concluded that work yesterday. What is left is for us, when we meet with National Treasury, to be very clear as to what we are asking for. When we meet with any funder, to be very clear what are we asking for. Because we could not go to them without having consolidated the work that we need to do. So therefore, as I go towards conclusion, what do we need to do? We need to make sure that no person living with HIV should fail to take or stop taking their ARVs because of PEPFAR withdrawal. So we're very clear that there are many students that are in the campuses that are relying on these services. In fact, we are going there, and I'll deal with the last 2 bullets just as I conclude. So we know that many students in the campuses are reliant on the services for pre-exposure prophylaxis, which we know now that the PEPFAR is not supporting. We know that they are reliant on the PEP, post-exposure prophylaxis, and we know now that they are not being supported. But I must assure the audience here that with regard to provision of ARVs, South Africa has always provided and bought its own ARVs. 90% of the stock that we have available now and into the future is provided for from the fiscus, and 10% is provided for by Global Fund. We woke up this morning to the news that Global Fund intends supporting us, and I'm sure in a moment they'll be able to send formal communication of strategies that they're going to put in place to make sure that we don't fail because of the withdrawal. So what are we doing? We're calling on all South Africans that are HIV positive to return and remain on treatment. Why are we doing that? We know among the students in the tertiary institutions, there's 1.1 million of them. They're part of the 1.1 million of those that have disengaged from care. We're saying in order for us to reach the second 95, we need to get 1.1 million people so that we can close the gap. We launched this campaign on the 25th of February, last week, Tuesday, so we're inviting people to come back to treatment. And secondly, because there are many young men at the institutions of higher learning, we want them to be part of the broader campaign of men's health called Better Men for Tomorrow campaign, which was launched and supported by the Deputy President of the country. Thirdly, we're saying all campus clinics must have referral system to the neighboring health facilities in the communities and vice versa, because we want to encourage the clinics also that are seeing patients that are stable and need to be down referred. They need to be down referred to the campus so that campus clinics and the clinics in the locality can work together to make sure that no one gets lost. Number 4 is that the packages of care that are delivered at the campus clinics are aligned to those that are delivered in the communities. Why do we want the alignment? We want to make sure that there is nobody who has difficulties in the continuation of taking treatment. Because if they are not aligned, when somebody lands at the campus, they may then find it very difficult. And lastly, and most importantly, we want the campuses to be pickup points for centralized chronic medicine dispensing and distribution, which is called CMMD. So with this, we are saying everybody who is in the institution of higher learning should not despair purely because PEPFAR has withdrawn. We want to assure South Africans that once we go with a consolidated piece of work that we're doing to those that are funding us, we'll come back and reprioritize. And what are we reprioritizing? We're going to have to say, firstly, what are the critical services that we don't want to drop the ball on? Because for us, both treatment and prevention are the two handles of the same plow. You can't hold one and leave the other. We need to start mopping the floor as we have been mopping the floor with treatment. But we also need to close the tap through prevention mechanisms. And we're looking forward to the day that the long-acting injectables will be authorized and approved so that our people can then be helped with the long-acting injectables, which will reduce their visit to facilities, but will also make sure that they walk around protected. And the other point that we need to emphasize is that the work that we're doing would have to make sure that we stamp out sexually transmitted infections, because those may lead to major complications in terms of reproductive health. Number two, we also need to make sure that nobody falls prey to the unwanted and unplanned pregnancies, because that are major disruptors in terms of the economic development and academic progress. So let me stop here and share and just say, as we are the Department of Health, we are available to work together with the three groups that have been affected by this. And we categorize these groups as follows. Firstly, I call these groups. First group is one, the researchers that are doing health-related research, working very hard in the institutions of higher learning and research establishments. They are very important. Number two, organizations that have closed down, which are providing employment to some people that were funding the students that are at universities, whom without that funding, their own children may find it very difficult to continue with the studies. Number three, and most importantly, but last and not the very least, is people that were receiving these services from our health facilities would want to say to them, we are planning to make sure that we sustain the services that were rendered. Even though we know that the PEPFAR is gone, we're assuring you that no one will go to the services and come back without having services delivered. But again, we know that other services of the key populations may have to continue to be rendered in spaces where people are very, very, very discreet, because they would want to be seen where there's no stigma and discrimination, perceived or otherwise. We therefore respect that and want to encourage collaboration in that regard. When we emerge out of mobilization of resources, we should be able to say, how do we cover the whole landscape as far as possible? Thank you very much, facilitator and the audience.
Thank you so much, DDG, for that really informative and positive response to what we are talking about today. I know there were quite a lot of reactions that came through from the attendees in terms of just a positive response to what you have presented. So thank you so much for that. I think there's a lot of work that's to be done, but I note that in the chat as well, there are a number of service providers and stakeholders and partners who have also put their information there. I think what's going to be critical is that we all come together and task share as best we can in terms of supporting our student population in ensuring the continuity of services. So thank you so much for that. We are now going to move on to our last speaker for today, Ms. Ntabiseng Mogoe, who is the Adolescent and Young People Technical Lead at SANAC. She is going to do a presentation for us in terms of the work that SANAC is doing and the gaps that are being mitigated in terms of responding to the impact of the USAID funding end. So, Ms. Ntabiseng, over to you. You have 15 minutes for your presentation, and then we will move on to questions and answers. Again, please put your questions in the chat. There's also a Q&A option on the webinar. So please do put your questions in. We will answer them at the end. Thank you so much, Ms. Mogoe, over to you.
Thank you so much, and good morning again, colleagues and guests. So I'm just going to share my screen quickly so that I can take you through my presentation.
Your screen is visible. Thank you.
Thank you so much. So I'm just going to quickly go through the presentation, colleagues, and some of the slides I'm going to jump through because it's elements that have been touched on so that we can also spare some time for Q&A at the end. So colleagues, I'm just going to start with the introduction, just to say that South Africa has made significant strides in the youth health program, because I'm going to speak specifically to the AYP program. So focusing on the age groups. So the age groups that we're looking at is 10 to 24, but those age groups are split because we look at where we find these young people so that it's easier to group them and also to target them accordingly. So we are having 10 to 14. We are also having 15 to 19, which we usually find them in schools, 10 to 14 primary schools, 15 to 19 secondary schools, and then 20 to 24, we find them in higher institutions, and then we also find them as well out of school as well. So we also need not to forget about those specific youth as well. And then we also note the challenge that we are actually facing as a country with regard to the funding that we have just lost, because we know the work that actually those organizations were assisting the healthcare system with. So we also really appreciate the role of higher health and as well as the Department of Health as well with regard to the higher institutions as well, because we are aware that in as much as the work is not as it was with the assistance from the donors, but the work is still happening in higher institutions to make sure that those learners are still getting health services. So we really do appreciate the work that goes. We know that there are clinics in other higher health institutions, and also higher health is also assisting as well to make sure that those learners continue getting their services, and that's really appreciated. So yeah, I'm struggling to move to the next slide. Apologies about that. Let me just quickly stop sharing and reshare. Apologies, colleagues.
Don't worry, Thabisang, these things happen very often with us, so take your time.
Okay. Yeah, because I'm failing to move to the next slide, but apologies about that. So colleagues, let me just try to continue without sharing my slides. I hope you can follow. I will try in the middle just to try to share them so that people are able to follow as we go. So my next slide is actually talking to the implication of this funding gap that we are actually finding ourselves in as well. So with regard to the funding gap, we know the assistance that we were getting from the US funded agencies. I'm not going to do a slide mode, colleagues, so that I can be able to continue. Apologies about that. So the US funded agencies have primarily supported 27 priority districts in the country. And when we are talking about priorities, we are talking about the highly burdened districts in the country. So you can imagine the amount of work that they actually contributed to this country. So we are not saying that we are actually not downgrading the amount of work that they have actually done, and also the amount of emphasis that they have actually put to make sure that our healthcare system is actually sustained. But we are saying that we are finding ourselves in this predicament, and as a country, what are we doing with regard to this? Data from the Department of Health suggests that we still having gaps that we are facing that are priority currently. So I'll give an example of the 1.1 million people that are still not linked to care. So we know that those are the things that we should be prioritizing on and not drop the baton, because yes, we are finding ourselves within this, but we still have priorities within the country. We still have things that we should be looking at and making sure that those things are still happening. So without this critical funding, we risk losing ground in closing the gap and impacting key health services. So I'm just going to share, colleagues, the funding that we're having for the two main funders for specifically the AYP program. So we're having the PEPFAR AYP program. So you can see on the left-hand side the coverage for the DREAMS program. So it was covering specifically 27 districts. And then also we are also having on the other side the Global Fund AYP program. So you can see that for Global Fund, it was only covering 14 sub-districts. So when we are comparing to them, these two fundings, you can see that Global Fund was having a smaller coverage as compared to the PEPFAR funding. But I think what we should be looking at, colleagues, currently is that we are not losing all the external funding that we are actually having in country, which I think it's the brighter side that we should be looking at, because we could lose both funding, but we still having one that even Mr. Mrewane has just mentioned that they are willing to actually support to make sure that we continue with the services that we are actually offering to our people in general, which I think it's something that we should be looking forward to. And then the other thing that I wanted to share, colleagues, is that usually when we're having an AYP program in country that is implemented, we usually do a geographic coverage where we actually look who is going to be implementing where, so that there is equitable share of these resources and there's also coverage as well. So what I'm sharing with you here is actually showing specifically the districts that we are prioritizing for the AYP program. The other ones are not visible here because when we are looking at their risk, they are actually lower. They are not here. But you can look at the ones that are highlighted in yellow, colleagues, are the ones that are covered by PEPFAR or were covered by PEPFAR. And then the one in orange are the ones that they were covered by both Global Fund and PEPFAR as well. And the green ones, colleagues, are the ones that we were actually planning to cover for the next grant cycle together with PEPFAR, because the agreement was that we cannot be all clumped in one district. Why don't we make sure that we do full coverage? We share these districts accordingly. So the plan was to move out of the ones that are highlighted in orange so that PEPFAR can remain alone there. And then Global Fund can concentrate on the other ones that are also high priority, but are currently not covered. But with that, colleagues, with the predicament that we find ourselves in, it means that we have to go back to the drawing board to say, with the challenges that we are facing currently, for the Global Fund grant, for the next grant cycle, what are we saying? Because we no longer have districts that we are saying this one's they will be covered. We know that we have to work very closely with the Department of Health to restructure to say, how can Global Fund now come in and assist with the districts that we are highly impacted? So those are the conversations that we are still going to be having with the Department of Health and other stakeholders as well, to make sure that the plan that we are having for the next grant cycle for Global Fund is going to actually make sure that adolescents and young people program, there is actually progress with regard to the HIV reduction, unintended teenage pregnancy reduction, and also the STIs as well. And then on the next cycle, colleagues, I'm going to talk about the domestic solution and existing programs. So I think we are lucky as a country to say that we are having government and domestic funding that have already laid the groundwork. The funded organizations externally, they're actually coming just to support, expand, and refine these programs. But those programs are already embedded within our structure as a country. And I think that is a good thing. And the current programs that we are actually having, I'll start with the in-school learners at 10 to 14 years of age. We know that we are having comprehensive sexuality education program, which is already embedded within the curricula of the in-school program. We are having the ISHE program that is supported by the Department of Basic Education, Department of Health, and also Social Development, to make sure that young people in primary schools are actually vaccinated, they are screened, and all those other basic health services. And then in health, in higher health education, 15 to 24 years of age. So for that one as well, we do have health facilities within this higher education facilities, not all of them. And thanks to also higher health as well, because it's also there to also assist with this population as well. But colleagues, I don't want us to also forget about this important population, which is the out of school youth. We usually call them the needs. They're not in education, not in any training as well. So this group as well, colleagues, it's very vital because unfortunately for them, we don't have them like in a particular school or where we actually find them in numbers. They are there out there in communities, and we also really have to make sure that we actually link them to services as well. So we do have health facilities where we actually have these youth-friendly services. So we have to make sure that the message goes out there to make sure that young people in all their diversity get these health services within our health facilities because they are there for them to utilize. And then the key challenges without the external funding that we are actually anticipating and we are already seeing as well is the limitation to the reach of AYP in different targeted spots. So we are talking outreach services, community AYP spaces, additional mobile services that were actually funded to assist what we already have. That's why I'm saying additional, because we do have mobile services to make sure that we do outreach system and services. It's just that they were not enough. And then the funding agencies were assisting in making sure that we amplify that. And then the potential gap in services as well. We know the amount of work and assistance that we were getting, the facility support, the resource enhancement, capacitation of our healthcare providers as well. So those are the challenges that we are anticipating, but we also have to also think and to say, what are we going to do in this time to make sure that everything that we have worked for, it does not go into dust. And then the impact on the national goals and priorities. We do have goals and priorities. We're having our national strategic plan. We are having the global coalition goal. We are also having the 1.1 million campaign that I have also just talked about as well, to say how do we assist each other to make sure that we are able to actually stick to this and make sure that the goals that we are having in place, we're actually able to reach them, even without the funding that have just been cut. The 95, 95, 95, we still have those, and it's up to us to make sure that whatever that we have learned or capacitated from these agencies, we still take them forth and then make sure that those things still happen.
Apologies to interrupt, just a time check, 3 more minutes.
Okay, thank you so much for that. Thank you. So I'll just talk to the collaborative approaches for sustaining services. So expanding outreach services, it's very important, colleagues. We do have innovations that have been done in country. Things like having community health workers, making sure that we reach communities. Those kind of things is things that we really need at this time. We are having youth-led organizations that are out there. They have been mapped. We have a database. How do we make sure that they are part and parcel of the innovative structures that we're actually coming forth with? And then I'll also talk about the last one, which is consultation and engagement with the communities. This is very important. The communities need to know what is happening. They need to understand so that they can also be of assistance. Like the first speaker mentioned, to say nothing for us without us. So that we have to make sure that people on the ground are involved and they are part of this as well. And then where to from here? So our commitment to ending HIV by 2030, it's very clear, colleagues, and South Africa's youth will be central to this fight. We have seen progress in the HIV prevention, treatment, and care over the years, and now it is time not to lose the momentum. despite all these issues that we are having. So let's make sure that we stand together collaboratively in different sectors, supporting the department, because this is not a fight for the department alone. It needs all those departments, it needs all civil society, it needs communities to stand together to make sure that we actually are somewhere with regard to the challenges that we are actually having within our country. So this is the time for us to actually stand together as a country to say we are going to stand and we are going to do something regardless of the challenges that we are actually facing. Thank you.
Thank you so much for that. A really informative presentation, and I think very clear in terms of where we are, and clear steps in mitigating the impact of the funding pause of USAID. So thank you, Ntabiseng, for your insightful presentation. Really appreciate your time as well in joining us. Thank you very much. Thank you so much. Colleagues, we are at 18 minutes past 11. So we have about 7 minutes for questions and comments. We won't be taking hands, so I would just kindly request that you do put your questions or comments into the chat so that we are able to answer those. I've received an apology from our CEO. He had to step out, but our Director of Programs, Mr. Bakile Finger, is online to take questions that are referred to Higher Health for answering. So I just want to look at the chat. I would really encourage people to also go through the chat. There've been a number of organizations and partners and stakeholders who have put their information into the chat, who have offered their services, who have reached out for collaboration. So if you are interested in that, please do look at the chat and the Q&A session as well, so that you can get the contact details for those people. As I mentioned earlier, I think task sharing is going to be how we work towards best mitigating this funding lapse that we've experienced. So I'm just going to go through perhaps to you, DDG. I will just put together. There've been 3 questions that have come through in terms of the Department of Health presentation. I just wanted to find out, so I think one of I'm just summarizing, but a few of the questions that have come through is, and you did touch on it, but maybe just to extend a little bit, are the plans for key populations to obtain specialist services. So there were specialized clinics. What is the plan to support that population? And I think, as you mentioned, students falling within the key population as well brings the relevance to the higher education sector. And then there was a question that the 2% contribution from private sector is too low. Can the department possibly engage with that sector to see if they can commit to a higher percentage of funding that gets shared with the country to support health programs as part of their corporate social responsibility activities? So I will hand over to you, DDG, to answer those 2 questions. Thank you.
No, thank you very much. Indeed, let me just first appreciate the Red Cross for making an offering to lend a hand. I think that's what patriotism is all about. So we greatly appreciate it, and I'll encourage them to reach out to. I'll write my email address, in the chat so that we can talk offline. It's not always about the size of contribution that is required, but it's also about just a good heart, of saying to South Africans, we are here, we're willing to help. So I think that's appreciated. Secondly, I'll deal with the private sector issue bill first, the contributions first, then I'll deal with the key pops. I think this almost takes us into the politics of health service delivery, because colleagues should know that, in fact, private sector in the main hasn't been treating HIV/AIDS as one of the key priority programs. What we keep on encouraging is that we've got many people that are employed in the private sector who are affected, infected, and therefore require their support. And indeed, we need to reach out to them to say, can we increase the size? They do contribute in some areas, I must say. It's not really all doom and gloom, but because when we go to Global Fund replenishment also, you'd always find that they contribute something as a private sector. But I think they can do more because, 2% is just too little. In fact, the 2% that comes from medical scheme is the money recycled from the people themselves. It's not necessarily an income generated by private sector. So we'll do that. Regarding the key POPs, I've said it in my presentation that we do look at the institution of higher learning students as a community on its own. In fact, it's a microcosm of our own society. It's full of all people, of all persuasions, political persuasions, belief, creed, religion, sexual orientation, and anything else. So therefore, our services working together with high health is to close in that gap to say those that are key populations who would otherwise not be seen in the mainstream health service delivery. We've got a program delivered by our unit in HIV and AIDS, working together with higher health in those spaces. So we'd want to just heighten our intervention in that space, and the colleagues know who we're working with. So the BWISE program is driven by us also. Obviously, we're supported by PEPFAR, but it's funded from our side. So we're aware of that and we'll take care of that space. And thanks very much for that.
Thank you very much for that response, DDG. That is much appreciated. I think it's just answered. I see there's some questions that have come in while you were speaking, but I think you spoke to that a bit in terms of private sector and foundations stepping up. I am then going to give over to Ntabi Singh. There's been a question and it received some reactions to say, is there any possibility of extending adolescent and youth programming age to not be 15 to 24, but to be 15 to 26, to include a larger number of students in terms of the support that's being given to them? Maybe just a comment on whether that's something that is a consideration, or maybe where the kind of allocation of that age group comes from in terms of identifying AYP. Thank you.
Thank you so much, Stephanie, for that. So with regard to the age group that is specified from 15 to 24 years of age, we are actually guided by the data that we get, because data shows that the young people, within the young people population from 10, maybe even above 24 years of age, when we are looking at the HIV rates, we see that it's actually higher within the 15 to 24 years of age. Hence, the way we have actually structured it to actually cover that. But we know that in South Africa, when we are talking about youth, it's up to the ages of 35. So even, like I said, we are having youth-friendly services. So youth-friendly services in public health facilities, they don't have a cut of 24 years of age. They do service even beyond that age group as well. And even in the funded organizations, when they are offering assistance to young people, they don't turn away the other age groups that fall beyond that age group. They do offer them services. It's just that we are guided by what the HIV rates are actually saying. Thank you.
Thank you very much. I think that's clear. That's a well-noted answer to that question. DDG, perhaps I can bring this to you in terms of, there are a few questions around what is going to happen to the NGOs that were largely funded by PEPFAR. It may be that you're unable to answer this question necessarily. Obviously, it's dependent on the NGO themselves and the diversification of funding that they received. But maybe just a comment, I think, on community healthcare workers and the NGO sector and what the impact there might be. If there's any nuance that you would like to add to, other than, of course, these organizations losing their funding, unfortunately, in the majority for some of them. Thank you.
Okay, thank you so much for the question. Maybe I can just touch a bit on that to say that we are aware of actually the capacitation that went into the human resources that were actually supporting or working within this organization. So obviously that does not go down the drain. There would still be open opportunities that obviously they will be having higher chances of getting because of the capacitation that they have, because of the qualification that they also hold as well. So I can't talk specifically to the organization because like you said, Stephanie, it all goes to what is the plan of that organization. But I just want to talk to the community health workers within those organizations to say that opportunities will still come, whether from the different departments, from the other funded organizations under Global Fund and others, that obviously they will still contribute and they will actually be get higher preference because of what they have actually gained within the US funded organizations. Thanks.
Fantastic. Thank you so much, Ntabiseng. I think that's really clear. Maybe just as our one of our last questions as we wrap up, I'm going to just ask Ms. Tobakile Finger to address this question. There have been quite a number of questions that have come through in terms of higher health procuring commodities on behalf of the sector in terms of perhaps PrEP, TB, commodities and HIV commodities. I know we really rely heavily on our partnerships with government and other stakeholders to be able to provide these commodities. But perhaps just an update in terms of, how we're going to work to ensure commodity provision, or what we're currently doing with Higher Health to provide commodities to the sector in the partnerships that we have. Thank you so much. Over to you, Tobakile.
Thank you so much, Steph. Good afternoon, colleagues and everyone. Thank you for that question. I think Professor Ramnik Aluwalia and Mr. Murawani, the DDG at National Department of Health, alluded to this. Higher Health has a memorandum of understanding with several provincial departments of health, and over and above that, we are required to have district MOUs, which some are in place, some are expiring, and some we are working on. And equally through that, we are then able to support institutions of higher learning with all the commodities that are required. Over and above that, I think Ntabiseng, in her presentation, she just alluded that Global Fund is funding several districts, of which higher education sector also benefits from that. And there's some commodities that are procured through that, mainly in our TVET colleges. And currently, that's the process that they will continue to receive commodities. That being said, as we are in this meeting, National Department of Health and Higher Health are currently in a meeting, particularly focusing on youth services that are being provided across the country, that is led by Megeti, and we are putting our heads together and taking stock of what services have been provided, where gaps are going to be in place. We've been really proactive since last year in terms of our planning. I think Mr. Murawani alluded right from the beginning that we've got joint planning with National Department of Health every year, where we take stock of what has happened in the previous year. And already last year, we were taking stock of the gaps that we are anticipating even prior to what has currently happened. So that process is in motion, and we will be communicating effectively.
Fantastic. Thank you, Tobakile. I think that's really clear in terms of the Higher Health, the support Higher Health is providing, the relationships that we've built on, and we'll be leveraging on going forward in terms of ensuring continuity of service provision and the support we give to the higher education sector. So thank you for that. Everyone, colleagues, thank you. We are at the end of our webinar. Thank you so much to our panelists who joined us, Professor Refilwe Faswana-Mafuya in her absence, and her colleague who is here representing her. Thank you to Mr. Rampelani Morewane, the DGG at Department of Health, and thank you to Ms. Ntabiseng Mokoe, AYP Technical Lead at SANAC. I just want to hand over to Tobekile Finger if there's any closing remarks. I think she summed it up well in terms of where we are and how we move forward. But Tobekile, over to you just for a few closing remarks, and then we will adjourn. Thank you.
Thank you so much, Steph. I think for us, it is just to appreciate, firstly, the higher education sector, the Department of Higher Education and Training, all the vice chancellors, the deputy principal academics, the principal, the student support units, for really working together with Higher Health to ensure that we are providing services to young people, and we are able to provide that. We really do not forget the strong collaboration of National Department of Health and all the provincial departments of health, SANAC. Let us really take this moment and appreciate USAID and CDC and all the PEPFAR partners for the critical role that they have provided in ensuring that routine services are being provided to our institution. However, I also want to highlight what Prof. Nancy has said in terms of community-led initiatives and what Ntabiseng said about youth-led organization. Let us continue to collaborate with our community-based organization that are around our institutions and make sure that we continue to do that. One thing that I would like to highlight, I think that Higher Health has done, is education as prevention, where we've integrated our health education into the academic curriculum to equip students with knowledge and skills to make informed decisions about their health. And we are really appealing to everyone to take up our civic and soft skills program. I hope the communications department will drop the link to everyone that may be interested. Once again, thank you, Ntate Morewane. Thank you, Ntabiseng. Thank you, Prof. Nancy in absentia, and to our CEO for the leadership that we've come through this far. We appreciate all the partners, even though we do not mention them by name. We appreciate their efforts and looking forward to the collaboration. We've dropped our email to say info@higherhealth.ac.za. Should you have any further information and engagements and collaboration, please use that email. We will be responding to all the emails that we are going to receive. We're also noting some questions that have been asked that have not been responded to. We will equally make sure that those are being attended to. Once again, thank you very much for attending this event. Back to you, Steph.
Thank you, Tobekile. You've summed it up perfectly. Again, appreciate really the panelists that joined us, but also everyone who works hard to ensure that students receive services. Wishing you all a wonderful rest of your day. The webinar is adjourned. Thank you so much.